Welcome back to Data Nerds. It's just me and Pat today.
Oh
Say hi,
yeah,
Pat.
the duo. Where's Brian at?
Um,
Bring it
yeah,
back. Tell Brian to stop making money.
yeah, exactly. Just hang out with bros on
Yeah.
the call. But what do you got for us today, Pat?
So today I got something spicy. Not really. It's not really spicy. I thought it was gonna be spicier to be honest, but we'll go through it. So I have a return to activity following a gastrocnemius release. I've seen a few of these come through our clinic. Have not seen any up till this point. Uh, Most of them are elective surgeries. Like we've had some patients that just get these because they say their Achilles feels tight. Um, this, this,
What?
yeah. Anyway, this gentleman got a gastroc release. I think for the same situation where, well, here. So this is a 18-year-old male, pretty athletic, played football, being 18 years old, is a high school senior with no real aspirations to continue on with sports outside of like recreational sports, from what he has told me. Um, so he's coming in because he had a right gastroc release back in March. He actually had the same operation on the left back in June of 2024. So I think there might be some kind of like congenital thing going on here, for why he's had both. I understand also that his left side might have been due to the fact that he also had a talar dome fracture that had to be repaired. So, or sorry, reconstructed. And so, the lack of dorsiflexion from that might have led to that operation. But the fact that he got it done on both, I think congenitally there might have been something. But in any case, I treated this patient for 12 visits over 6 weeks, roughly, starting at post-op week 5. I believe, off my memory, he was only in a boot for like 2 weeks, and then just transitioned into a sneaker. And when I started seeing him, all he's been doing up till this point was just range of motion and light, like therapeutic exercises, like your ankle wipers for eversion, inversion, and like light plantar flexion. And so our first 2 weeks really just emphasize continued restoration of range of motion with slow progression into heavy loaded plantar flexion once range of motion really started to stagnate. And to give you some context, patient is and was less than 3 inches for the needle wall test bilaterally, which, from my understanding, like a 4 or even 5 is kind of where you want to be pushing for like quote unquote normal or like good closed chain dorsiflexion. Would you agree with that, Mike?
Yeah, I actually say a lot of our runners, I'd say we want like 4.5 inches. Most
Okay.
people that we see are not at the 4.5 inch mark.
Yeah. Yeah. And so, in the top here, we see a illustration of the different gastroc release techniques. Some of these are more so for pediatric patients. I believe like the Z technique is one utilized for pediatric individuals, while the Strayer technique, is the one that I've seen most often if you're an adult going in for this. And if you look at it, it is a just clear cut of the gastroc, right at the insertion onto the Achilles tendon there. So I was kind of skeptical about what kind of function this kid was going to come in. Just, thinking about how much force is required for things such as like sprinting or short distance deacceleration that whole calf Achilles complex plays into. And, I figured there might be some pretty stark impairments that go on here. But my plan, kind of like what I said, restore range of motion much as possible. Begin heavy, slow loaded plantar flexion, supplementing like balance exercises and accessory ankle motions. And then near the end here, continue into like RFD and high load close connect chain actions like your acceleration positions. I normally did this through the use of like sled work, starting off of like some pretty heavy sled work to then progressing the weight off of it and shortening the distance to then drive more of that, what is a true like acceleration. And just always watching for like a heel drop or like a very quote unquote loose heel to where on push off you kind of see a extension through the knee, just can't really keep a rigid ankle. um so also, I guess, to caveat being, this is a pretty quick plan for 6 weeks. I did not expect us to progress through this. um I figured this plan would take many months, especially since an article I read talking about returning to physical activity for someone after a gastroc release, it could be anywhere from 2 to 24 months. So it's like really up in the air about like how long is this really going to take and how quick can you go? Um,
Do you
so
think that oh, I have a question. Do you
no,
think
yeah,
that could be related to like what technique is used?
uh, potentially. I believe in the article I read, it was majority was the Strayer technique, the one that's just
Gotcha.
like that clean cut across. Um, but yeah, potentially, I'm not putting it past that. And so it came to our last session as of that time period where I had him fill out an outcome measure. We were just going with the LEFS. He scored it at like a 60% ability roughly when he first came in. And then he was pretty much 1 point off from being a perfect score on it on this progress note. For anyone who's unfamiliar, that essentially means he does not feel like he is impaired by his uh impairments, I guess, following surgery. This essentially means that he's functioning at a normal for him level. And then upon like subjective report, he does not feel like he's limited in any regards. It's more so he hasn't really engaged in some of these activities that he might want to do, but based on what we've done in the clinic, he does not feel like he's restricted at all and has really no pain at all. So our two tests we have the run specific ankle isometric push and the 10-time repeated double leg hopping. I couldn't get the 5-10 hop test where you take the best 5 out of a 10 times repeated hop. But essentially what I told this patient is to be quick off the ground and get as high as possible. After the first 3 reps, I use those first 3 as kind of like your rhythm setters to then progress into your very intensive hop. So this is a double leg pogo essentially. So,
I have a
uh,
question before we go too much into these.
yeah,
So he's 18, has this thing now on both sides, and is he like purposely not like is he scared to do the activities that maybe he did prior, or
no,
he just doesn't really care to do them?
right. I think it's more of the latter. He had aspirations to play senior year football, and that I would say 25% went through, and football, from my knowledge, is his only sport. So now with football being done and being a senior in high school, it's more of, he'll just do pickup whenever he wants. But right now he's not really engaging in any true like structured activities. So to your point, I think what you're kind of getting at, Mike, is the ceiling or the bar that we're trying to achieve is much lower than one who might be like a sophomore in high school who still has like 2 more years of competitive play, right? So think that's a good point. I don't know if that's what you were getting at, but that's kind of where I took
Yeah,
it.
and I guess I worry about where his function will be the rest of his life, essentially.
Exactly.
Because
Yeah.
like maybe he doesn't care to do those things now, but like, what if when he's in his mid-20s, he wants to get back to I don't if maybe he wants to start, hiking
Something
or
else.
playing
Yeah.
basketball or something, and then like he just doesn't have that function from this. Um, which
Right.
is just
Yeah.
something like that's what I see a lot. It's not that I see that, but like the idea of setting yourself up to be better later in life,
Hmm.
and like optimizing your long term is something that I
Hmm.
see a lot, being out of network because that's what people want to pay for, essentially.
Yeah.
So
Yeah. I essentially took that upon the plan to where I think it could have been easy to not do a lot of these tests, because to your point, he isn't really in structured activities anymore. But to what you said, because of his age, I explained to him on day one that I want to get him back to being able to jump, sprint, cut, do these things. So and he has the availability to engage in those one might say like health promoting activities or like social engagement activities, Um, so yeah, not having the ability to say yes to things at such a young age is pretty impactful, like I feel like for a lot
yeah,
of these younger patients, being able to keep them to just be able to say yes to a lot of things that come up in life, not just from a health perspective but a social perspective, is pretty big. So that's kind of like, you know the direction I took it, for the plan. And he seemed pretty on board, but we'll take a look at kind of how he did
yeah,
here. So run specific ankle iso, the way I completed it is kind of out of line with what Vald might have written. When it comes to Vald's actual completion, I think they tell you to do like 2 warm-ups, and then the three actual ones are only meant to be 3 seconds long, not 5 second long. And they also are supposed to give you a minute rest in between. um, I did not do that, partly just because of timing and discussion, um, and also familiarity for the patient, because we have used this method already as a training stimulus. So just to keep that continued and not like change the environment too much through the actual completion. And then I put the patient's body weight there because I thought I was going to put the calculations, but that's on the next page. So, um,
um,
and
can you explain how this test is done, or maybe you do that later? So
no, I'll explain it now with the photo right here because
cool.
I think that would be most appropriate. So in the photo here, we have someone completing the run specific ankle ISO push test. If you do not have a nice fancy isometric frame like what's in the photo here, a good option is you either place a barbell and load it up very, very heavy. I find that method very time consuming. So my best recommendation is to take some J hooks and just flip the J hooks upside down and do it that way. That's a lot quicker from a changing of position standpoint. Um, and so for the setup, you want someone to have their knee relatively extended and then to be in anywhere from 0 to 10 degrees of plantar flexion. So that's what this gentleman is showing here. And I think a big caveat that comes with this test is proper footwear, because that degree of dorsiflexion you're in is going to be way off comparatively to what shoe you're wearing. Because, like, I'll give you the example of the patient I was working with. He was wearing the Nike Air Max 270s, which is a lifestyle shoe that has a heel to toe drop of 16 millimeters.
Holy
So,
cow, that's a
yeah,
huge drop.
yeah, which would also explain why he wears those shoes predominantly for someone who has pretty, lacking
Tight,
dorsiflexion.
yeah.
Yeah. Um, but so relatively already, he's going to be in a lot of plantar flexion. So that's where I give a little bit of grace to the values that we see. But we'll take a look at it nonetheless. Any other questions around this testing, Mike?
No, just a comment. Because I know we both did the Dungeons and Dynamometers course. Shout out to Jason and Chris. Good course. But I know when I did it, we talked like there was a lot about calf testing. And one of the things we talked about was standardizing shoes for it.
Yeah.
And actually, one of the guys that was at my course, like one of the people taking the course, he like built his own calf strength testing unit, which is just wild to me. And he standardized it by using a one of the like rigid shoes that like essentially like a post-op shoe, not like a full-on boot.
Oh, yeah.
But the like rigid like just the like sandal thing.
Yeah.
And I thought that was genius for one. It worked better in his setup, but I guess I say that being that's one way you could standardize this. I don't think that would work too well on on something like this. But
Mhm.
just definitely a big consideration is like footwear. Because a softer, more cushioned shoe, you're just going to have a lot of give from the shoe itself, which may not be um, factored in to the final numbers.
Well, yeah, it's like two things that go of that is the compliance from the shoe is going to change your RFD because you're just pushing through that compliance and not into a rigid. So a lot of force that would be going through the plates is getting dissipated through the cushion throughout that first 250 milliseconds. But then also your peak force is probably going to be lower because of the compliance. You're going to be pushing into it, which then is going to put you into a greater plantar flexion degrees, which then is going to decrease your plantar flexion output because of us knowing that your greatest plantar flexion output is within degrees of dorsiflexion. So, yeah, I agree. Like the standardization of shoes is quite important. This guy did wear the same shoes. I did do this actually a while ago, but we're just going to look at the final day because it was honestly the same values and he did wear the same shoes. So, anything else with this, Mike, or
No, I'm interested
no?
to see
Okay.
what the numbers are.
So, boom. Oh, a little teaser here. Um, what do we see here? So I'll give you a little insight. The blue is the left, and the orange, or sorry, the red is the right. What do we
Okay.
what do we think?
The left overall looks higher than the right.
Yeah, there we go. Someone passed art class. All right. All right. Let's so I took out just the relative peak force and the actual absolute peak. And then I also put the CV down there because I think that's pretty important. And we'll go
Mhm.
into the problem with the left side. But so
Yeah.
looking at it, here, relative peak vertical force. So if we're going based straight off of Vald, their data set, a team sport male should be hitting 3.1 to 3.3 times their body weight for the ankle iso push. My patient was hitting 2.88 on the left, 2.43 on the right. So, pretty far off from that goal.
Yeah.
If someone, if we're talking about someone from team sport where like that is definitely where I would put this patient being a football player. Um, then we're looking straight at the peak vertical force. So this is the true peak. This is not like an average value. This is the highest number
Mhm.
that was achieved throughout all the tests. And there's a 16% deficit. So if we're going based off recommended standard, 10% is usually what people are trying to look for. 10% also carries through for CV or coefficient of variation, where that's kind of looking at how much is there a swing between your outputs. The right side is actually pretty clean. The left side, not too clean. And usually the recommendation is if you're above a 10%, you should repeat the test. But reason being for the left side, the patient gave a false fourth effort. So
Hmm.
he like pushed up into the squat rack and it recorded it on the left because he was like switching feet or something. And I did not delete it in post analysis. And so it just like calculated it. So I am not putting too much weight into it because the value was significantly lower as compared to the other ones, to where it looks just like the right, like the values are within the same swing of those three, that I believe if I took out that last false one, we would be pretty clean. So
Cool.
yeah.
That's
So
it's good to see that, even so the left, we could say uninvolved in quotes, that there's still a deficit there,
yeah.
compared to the Vald goal, that
Yeah.
because he also had the surgery there too.
Yeah. Exactly. So interpretation, kind of already talked about this for the CV. All testing and rehab thus far has been pain-free and has responded well. And like I said, I'm going to give grace to the results a little bit due to the time constraints on setup and the completion, and then also the choice of sneaker that was used. I think a few good points that should be brought up throughout rehab is I was anticipating a bit more of a deficit in terms of heel raise and plantar flexion strength ability, challenging him through both closed chain in terms of like very heavy sled pushes to kind of see how does that heel favor in terms of creating a very rigid foot for him to push off of. But then also just, how many heel raises can he do under load? And uh, I think that in itself is giving me a lot of good value into what is continued to be important, because he obviously has some kind of rigidity still, whether that rigidity is just because he lacks a lot of dorsiflexion. So he's kind of just hanging out on his end range dorsiflexion. And is it getting pushed much farther? You know what I mean? um, or if just the supporting extrinsic foot muscles and that soleus are kind of just putting in overtime to do a good job. But um, as what's next, when I discussed with him, continue to prioritize plantar flexion strengthening, because during his last sessions, we were doing some oopsies. Um, we did some like quote unquote heavy calf raises. It was a 55-pound kettlebell, so I don't think it's anything actually heavy. But
Dude, that's a single leg, like standing single leg calf raise
yeah.
with a 55-pound. Doing 26 of those is pretty impressive in my book. But
um, well, so he could only do like less than half on the other foot on the right compared to the left. I just realized I put that ass backwards on the actual numbers there. His right was 12, left was 26.
yeah,
And that was to complete failure. That was till he just could not go up more than like halfway essentially, and then just dropped. And then so essentially what's next? I think with this patient, I'm giving a lot more grace into his subjective report than my objective findings, just due to the fact that of his situation. He, been through this surgery before. He's gone through it again now, progressed very well throughout rehab, and is telling me that he does not feel limited at all. And so we left off on this idea of, okay, I want you to go out for 3 to 4 weeks, come back to me, and we'll talk about any sticking points you might have had with the idea that I want you to go and do things and don't be stupid. Obviously, like don't go out and just start doing like sprints. Like if you're hanging out with your friends and they want to do something, like just go out and do it. But just come back and report that if you had any kind of issues with anything, and if you come back and you say, no, actually, I'm living life, I don't really think about it, don't really have any problems with it, then we'll just discharge and go from there. But it's kind of like I don't want to say like what's the word I'm looking for? Um, like the ending isn't like anything grand, if that makes sense. Like
Yeah.
I don't think the ending to this rehab is going to be like some amazing like return to sports story. Rather it's just a teenager who just, feels like he's just able to get back to life, which, like, hey, you know what? If that's just what he wants to do and he's able to do it, like, God bless him. So
Yeah, I feel like that's we always want to hear about the comeback stories and like how, the I think about like the ending of The Sandlot where like the guys like slowly, fade away.
yeah.
Um
Yeah.
it's like we'd love for that to happen in real life with our patients, but you know, as you said, if he just wants to enjoy doing whatever he does, not need to go back to high level sport and is cool with where his function is, then like
Yeah.
who are we to make it like force him to do a bunch more exercise?
Right. Yeah, exactly. And so I think 2 points to that. Um, I didn't tell him that he should just stop, like still using objective data, and kind of like what we discussed earlier in this episode of, hey, we're still seeing deficits. I'm glad you're feeling amazing, but I think for longevity purposes, it might be in your best interest to continue to do some heavy like plantar flexion strengthening. Um, and then to kind of what you just immediately said, Mike, where we do objective testing, of course, to try to hit criteria to prepare people the most for what they want to do. And then I think it is sometimes within us to recognize that sometimes people don't have the highest bar that they're trying to achieve, and that sometimes objective testing, although insightful, shouldn't be a persuasion point if someone is just trying to get back to just doing, regular ADLs.
Yeah.
So,
Yeah.
any questions? I feel like that was kind of I want to say a sad ending, but it definitely was kind of anticlimactic for an
Yeah.
ending.
Yeah.
But
Yeah. How far is he post surgical at this point?
what is that? Let's see. Off the top of my head, it's got to be like,
It's
oh
like 11
brother,
weeks.
yeah,
Uh,
it's 11 weeks as of tomorrow.
Okay.
Yeah.
That's
So
that feels like such a like I agree. I would have thought this would have taken a lot longer. I've never seen a gastroc release, so you know, I don't have anything to base that off of other than just like I think about an Achilles repair, which
right.
is obviously a lot longer of a, of a rehab than this.
Right, exactly. So, um, yeah, I was kind of shocked also at how much this kid was able to handle through just like heavy loaded strengthening. And then even by the end of our treatment sessions, I was having them do very light sled pushes for like 5 meters to try to replicate that acceleration position at super high velocity. And like he had no symptoms. Heel was keeping high, like very rigid ankle, and like, all right, I guess. Like I said, I think part of it might be he's just hanging out on that end range of motion, but I guess a rigid ankle is a rigid ankle, right? So
Yeah, if it works.
yeah,
Yeah. Yeah. Well, cool. That's it's an interesting case, yeah. Never seen that. And I haven't used that the test either to like run specific ISO.
Hmm.
Do you like that as a, like, I know you said you worked with him on this before, like as
Hmm.
treatment, like, do you like that as a treatment too?
I do, yeah. Like if I'm thinking about loading in a more closed chain fashion, I think it's a good way to drive stimulus through kind of like how we would for any other isometric, where um, I think it can get a lot more intent out of it rather than just having someone do a lot of heavy heel raises. Um, and I don't know, I enjoy it a lot. The only
What do
thing I
you
have, what's up?
you finish before I ask my question?
Oh, I was gonna say the only caveat to that is you have to just watch the knee positioning just
Mm.
because, being a whole closed kinetic chain motion, um, someone might not just have like the greatest stiffness through their knee while they do it, and it just might look very shaky. But then, in my opinion, like that could be a good reason to do it is to build like holistic lower extremity rigidity, especially if someone's trying to get back to like sprinting.
Yeah. Yeah, that was kind of going to be my question, was like, do you cue anything specific? Like, do you try and have, like, do you position the bar and J hooks at a spot where like they have to have their leg fully extended and be in a little bit of plantar flexion to do it?
Mm.
And like you're
Hmm.
telling them only to like like the goal is essentially only plantar flex and not like extending the whole leg.
Yeah. Yeah, it definitely takes a little bit of finagling to get the positioning just right, but um I essentially find a position to where I give them a few testers of like, okay, I just want you to push into this like 50% just to make sure positioning looks what right. You don't feel like you're sliding or the bar is slipping on you. And then once we find that position, I cue them to just push up as if they're trying to drive their head up towards the ceiling. Because that's one of the caveats I find when I do any kind of plantar flexion loading is people will start to translate forward where they kind of just roll their foot forward and translate all their body weight almost like a trunk lean instead of doing an actual heel raise of bringing their weight in a superior inferior or a rostral caudal kind of motion.
Yeah. Yeah, I was thinking we probably should have gone over that when when we first were talking about the test instead of at the end. Um,
Oh well.
but I mean, we got to it, right? So
Yeah.
hopefully people listen this far. Um, but I think that's useful, like for if people want to set that up themselves, and you don't need force plates to do this either. You can like as you said, like squat rack with some J hooks and a bar, like that's good enough.
Yeah. Yeah, exactly.
Yeah, I've been thinking about using this more with my patients. We often aren't doing exercises like in the clinic, and it's
Yeah.
more of like, oh yeah, go do your exercises when you can, and not everyone has access to a squat rack to do these.
Yeah.
Um, but yeah, I think that's a good place to stop. So as always, if people have watched or listened this far, we always appreciate a nice review on Spotify or Apple Podcasts, or leave a like and subscribe on YouTube if that's what you're doing. And follow us on Instagram at Reading Rehab Pod. Thanks.